Hi everyone, I'm Darlene with QRS Educational Services, and in this session we're going to be looking at the different parts of the 12-lead ECG and how they correspond to different parts of the heart. When we take a look at the 12-lead ECG, we are essentially looking at three parts of the left ventricle. Leads 2, 3, and AVF, they look at the inferior wall of the left ventricle. V1, V2, V3, and V4, they look at the anterior or the front of the left ventricle. Lead 1, AVL, V5, and V6, they look at the lateral wall of the left ventricle. A method that was developed by us many years ago talks about the boot, the gun, and the leftovers. And that's a really great way to remember the various complications to anticipate with types of MIs. So when we think about the boot, the gun, and the leftovers, take a look at the ECG groupings. And yes, you can see that the boot is the inferior wall, kind of like the shape of a boot, right? Well, we wear boots where? On our feet. On the bottom of our body is where our feet are. So if you're seeing the boot shape on the ECG with ST elevation, the boot, it's the bottom of the heart, the inferior wall. Okay, so the boot is the bottom. The number one complication to expect with an inferior MI is they are going to bottom out their blood pressure. We're not surprised when that happens. There's two reasons why an inferior STEMI will become hypotensive. The first is because almost 50% of inferior STEMIs also have a right ventricular MI occurring at the same time. So for your inferior ST elevation MIs, you always want to do a 15-lead ECG. Treatment for a right ventricular MI, apart from just the MI part of it, which is a separate topic altogether, because they are hypotensive, you are usually looking at giving them fluid administration. Could be 1 liter, sometimes even 2 liters of saline, as long as the chest remains clear. You would not give a patient having a right ventricular MI nitroglycerin, because that will exacerbate their hypotensive crisis. The second reason an inferior STEMI may become hypotensive is because they are experiencing bradycardia. It could be a significant sinus bradycardia or perhaps a third-degree AV block. Treatment would be to initiate pacing as soon as that happens. Let's move over to the gun. When we take a look at the anterior wall, it's kind of the shape of a gun. The gun, that's dangerous. And so is this infarct. It is associated with the highest mortality, not only in the acute phase, but also long-term. The reason being is that the left ventricle is the strongest part, that anterior wall, it's the strongest part of the entire heart. So when it is infarcting, the pumping ability may be so affected that it starts to back up. Now, where does the left ventricle back up into? The left atria and then into the lungs. So the number one complication we expect with an anterior infarct is they will develop acute pulmonary edema. We need to auscultate their chest. We need to be very aware that this complication can occur. As soon as we identify it's happening, we call the physician stat, and we would expect to get an order to initiate nitroglycerin. Whether it's sublingual, whether it's intravenous, the secret is you need to be giving not just one spray or 5 mics IV, but you need to give it frequently, because what nitro will do is it vasodilates and it reduces the amount of blood coming into that overburdened left ventricle. Some patients with anterior infarcts may have such problems with the pumping ability that not only has the fluid backed up into the lungs, but their forward motion in terms of their blood pressure is also impacted. They are now hypotensive. They may be frothing out of the mouth, pink sputum. This is cardiogenic shock. Some people refer to it as flash pulmonary edema. This is very life-threatening. It is associated with really high mortality. And for those patients to bring up their blood pressure, we'd be looking at usually a level-fed infusion, perhaps dopamine. If we can get them to the cath lab, research has shown they have better outcomes by going for intervention. The last group on the 12-lead ECG is the lateral leads, which are the leftovers. And really what you need to know about the lateral infarcts is they usually don't occur in isolation. They are usually combined with an anterior MI. So to have an anterior lateral MI means that the chance of them going into acute pulmonary edema or cardiogenic shock is even higher. So I hope you have found the boot gun leftovers to be awesome. We have them in pocket cards. We also have our Heart of the Matter manual, and we have a whole bunch of on-demand courses that are going to be hopefully addressing anything you need. If you have any questions or comments, please let me know. Thanks.